So, as Maggie mentioned, I'm the founder of AlayaCare. So our purpose as an organization is to enable the type of care that we would want our loved ones to receive at home. We're a software provider. Our customer is typically the home care agency or the provider of home care. And so to enable the type of care we want our loved ones to receive, we have no choice but to essentially be the operating system for the home care provider. So that means our customers essentially run their business on our software. We do everything from patient intake all the way through to the development of the care plan, the matching with care workers, developing of the schedules, and then 550,000 visits a month now happen on our mobile app, caregivers out in the field delivering care, documenting that care, and then getting on to the next visit in their day. Amazing visuals to illustrate this. Take my word for it. So we're coming up to our 5th birthday in August, and it's been a hell of a ride. We're 150 some odd people now. We serve Canada, the US, Australia. We have customers in the Middle East, and Singapore, and Hong Kong. And the benefit of being across these multiple jurisdictions and seeing how home care is organized and delivered in different markets with different payers and different health systems is we've been able to step back and develop a point of view on what successful home care means. Perfect. Oh, here we go. What successful home care delivery means and what the trends are in the space and how us as a humble technology provider to the space can impact those things. So number one, insight. There is a very high correlation between the level of satisfaction of the caregiver and the level of satisfaction of the recipient of care. And literally customers of ours like Nurse Next Door that survey this data in real time see those two lines move almost together. So often in the triple aim framework, sometimes the caregivers are not considered adequately, particularly in this space where demand exceeds supply and where that condition continues to get worse over time. Anything we can do to give a better experience to the nurse, the therapist, the personal support worker is indistinguishable from work we do to enable great care to be delivered. Next insight, because we power clinical care delivery and non-clinical care delivery, and ultimately we're tracking outcomes for patients. The next insight is social determinants of health. Things you hear in academic research play themselves out on the field every day in every home for every patient. And sometimes the intervention for a COPD patient that's going to be more effective than any clinical intervention is making sure the air conditioner is working properly. So social isolation for seniors, making sure people recovering or living at home with conditions have a good environment to live in and have companionship and so on, an absolutely essential part of good care. And finally, there's a lot of discussion around how technology can enable more virtual care. We happen to have remote monitoring and telehealth tools built onto the same platform that's used to enable the traditional in-person healthcare. We've been, I would say, ahead of the market with this vision since when we started. In fits and starts, it's catching up. But health systems and the silos of funding do not serve the patients very well. And we're seeing models evolve around the globe that are, the more you pay for an outcome, the more technology pays itself. And I want to just take 2 examples to illustrate that. Number one, in Australia, very similar market to Canada, although there healthcare is a federal, not a provincial mandate. All publicly funded home care, as of February of last year, shifted to a client-directed care model. In other words, you get assessed as a level 2 package, Here's $37,000 a year. Go find a certified home care provider and negotiate with them the care you want to receive. When the patient's allowed to choose how to spend funds on their own care, guess what? Some people will choose the virtual tools, others won't, but there's actually a functional marketplace around care to deliver patient choice. So example number one. Example number two, in the US under Obamacare, plenty of good and bad of the model, but one thing you would have probably heard about is the readmission penalties that were part of the Affordable Care Act. And rather than saying, hey, we're going to find this bundle of money and we're going to allocate it to remote patient monitoring and telehealth, all they said was, hey, hospitals, hey, nursing homes, 3% of your budget is at risk if patients get readmitted within 30 days. And then our little corner of the universe, the home care providers, instead of showing up at their referral partners with a box of donuts saying, hey, send me your referrals, my caregivers are very caring, had to start showing up with data saying, here are our readmission rates. We will fund remote monitoring interventions ourselves because research shows, our numbers show that in the first 15 days, XYZ intervention will reduce your readmission rates accordingly. And so all they needed to do was create an incentive and the market organized to deliver the innovation. So I think there's some good lessons to that, particularly in Ontario, as we're reorganizing our delivery system here. So that's AlayaCare, and that's home care. Thank you.